Good morning. I'm Meera Mohan. I'm one of the clinical faculty at the Medical College of Wisconsin. So we will be presenting our work on the real-world data with Teclistamab in patients with relapsed refractory multiple myeloma. So Teclistamab, as we know, is the first-in-class BCMA bispecific antibody that was recently approved for relapsed refractory multiple myeloma in the fifth line. So our real-world data is important because clinical trials have very strict inclusion and exclusion criteria. Patients with rapid relapsing myeloma or patients who have suboptimal organ functions are typically excluded from clinical trials, and that's where real-world studies such as ours comes into play. So in this real-world experience, we have about 110 patients who've got teclistamab. So unlike the clinical trial, this is a very heavily pre-treated patient population. That means they've got a median of 6 prior lines of therapy. Almost all patients have had a triple class refractory disease. That means they have got an IMiD, PI, and CD38 monoclonal antibody, and the disease is refractory to that. In our study, 35% of our patients got a prior BCMA-directed therapy. This is unique because the pivotal clinical trial that led to the approval of teclistamab did not include this study population. Our follow-up is about 3.5 months, but we see an overall response rate of 62%, with 50% of our patients achieving a VGPR or better. Complete remission rates were about 20%. In the study, we also looked into safety signals, the incidence and grades of CRS and ICANS. Overall, CRS, which is cytokine release syndrome, commonly seen with this class of agents, was seen in 56% of patients, and ICANS in about 11% of patients. So there were no real new safety signals. We were also interested in understanding the infections with this class of agents in the real-world setting. So what is unique in our study is that we have implemented infection prophylaxis measures. Nearly all patients are on herpes zoster prophylaxis. About 57% of our patients received a primary PGP prophylaxis, and 46% of our patients were also on primary IVIG prophylaxis, meaning they had IVIG prophylaxis irrespective of the IgG levels or history of prior infection. In this context, we still note that the cumulative incidence of all grade infections and high grade infection was pretty high. We also note here that primary use of IVIG supplements led to a reduction in high grade infection, and that is really the takeaway message in this abstract. The real-world study here shows that teclistamab in a heavily pretreated patient population, which is a real-world population, showed an impressive overall response rate. Infection remains high. However, primary IVIG prophylaxis led to reduction in all grades of infection. Thank you.